In this episode of the Nurse Practitioner Podcast, Victor Czerkasij discusses acne. What is the prevalence of acne? How common is it? And what are some of the issues surrounding treatment?
That's a great question. Acne is very prevalent, especially in dermatology. We know that at the end of the year, about 12% of all dermatology visits, as measured by ICD-10 codes, will be a diagnosis of acne vulgaris. Vulgaris, of course, meaning common. In fact, we look at about 17 million people with this common skin disorder in America on an annual basis, and it is the most common dermatology diagnosis. Unbelievably, while it's so common and it's not life-threatening, it's also considered by many of us to be one of the most difficult conditions to treat. We find that while it sounds to be simple, a bacterial infection, as most providers would know, we know that there's issues of difficulty surrounding treating it. For example, compliance. Many of the acne patients we treat are teenagers, and teenagers are notorious for having their moms and dads yelling at them from downstairs, "Have you used your acne medication?" So they're not very compliant. Another thing is side effects. We know, as we'll be telling you in this podcast today, is that oil production is a big issue. So if you reverse engineer that, we want them to be dry. Well, drying could be itching, burning, especially around the eyes, nose, and mouth. So that makes it quite an issue surrounding treatment. Other things are interactions with medications. You could have two products that don't work very well with one another. We have one, for example, a topical, where if you use it along with benzoyl peroxide, you can turn orange. While it's temporary, it would make for an interesting day at class, at school. People get discouraged, young people will, because they're drying out and the side effects, and maybe they're not clearing as fast as they want. Also, we know that acne, a bacterial infection, is continuing to be very resistant. So we have multiple strains, and young people will pass their buff pups to one another. Let's say a young lady is in a bathroom and wanting to put on some makeup, so she'll borrow the makeup brush from her friend and put it to her face. Well, you can transfer her strain of acne now to your face. So we do find it quite challenging. I think if anyone remembers the old photo of blind scientists touching an elephant, one could be touching the tail and says, "Oh, the elephant's like a rope," or another one is touching the side of the elephant, says it's a wall. Maybe one's touching the ear and says it's a fan, or maybe one's touching the tusk and says it's like an elephant is like a sharp spear. The point is that there's a lot of opinions on ultimately what acne is, its pathophysiology, what's the best way to treat it, but you have to find that a good discussion with a family, along with usually the teenager, asking how compliant they'll be in getting that right fit for the patient. So we do have issues surrounding treatment around this very common condition, which is not all that easy to treat. One more point I'll say before moving on to your next question is that some folks would be surprised when I say this comment, but I think at the end of the day, doing this dermatology for a few decades, I think that skin cancer some days is easier than acne. And that shocks some folks, but think about it. If you have a skin cancer on, say, your left arm, we'll cut it out as an excision. We'll sew it together. We send that tissue off to the lab. We have free margin. You're cured. I mean, that's done in one day. I've cured your skin cancer literally in one day. But acne can persist for months, if not years.
What is the pathophysiology of acne, and how does it get its name?
Well, when we look at pathophysiology, what are we really asking? We're asking, what is the mechanism behind this condition? So let's take a look at the word acne itself. Acne is the shortened term for the bacteria that's prevalent on the body in areas of oil production. It's called Propionibacterium acnes, or we call it P. acnes, or just Acne vulgaris. It's a bacteria that lives even on your grandparents. Sometimes we'll do a culture and sensitivity on an 85-year-old woman. She had a cut, let's say, on her neck. She maybe fell down. We'll do a culture and sensitivity, and one of the bacteria that come back is acne. The thing is, while it's a bacteria that lives on the surface of our skin for our entire life, it's particularly prevalent when we are teenagers. Why? Well, if you take a look at how the oil production is distributed on the body, we're talking about sebum, is the word. The sebum glands are on the scalp, face, neck, chest, shoulders, back, to a certain extent on the buttocks as well. But you won't see acne on the forearms. You won't see it really developing on the abdomen or on the thighs or legs. That's because we don't have the sebaceous glands distributed there. But when you have a teenager who, by virtue of where they are in life, they're growing, they have activity based on their hormones, or we call them androgen. For a female, it would be estrogen. For a male, it would be testosterone. When you have that added production of oil, now you've created an environment for this bacteria to take off. And what happens is, as it proliferates in the glands, the oil glands or sebaceous glands of the face, chest, shoulders, and back, this oil-rich environment, it also irritates these glands. And you can have some what's called hyperkeratinization, and that's where you can have desquamation or the scaling of these flakes of skin. So you have oil production, you have the proliferation of the bacteria, you have the irritation and inflammation now thanks to this desquamation. These hormones are raging, and they're really pouring out the oil. And as the bacteria grows in these glands, it pushes up against the pore walls. And now you have these blisters, these cysts, and the scarring that takes place. So it's very, very uncomfortable, and psychologically, the effects on the young person is profound, especially the social aspect. This is the Instagram generation. These are the people that love to put their faces and their activities out for everyone to see. But the young people will come in the middle of summer with hoodies, they grow their hair longer, they cover themselves up, they pull their collars up, they don't want to be seen. It's really impactful when they come in. So when we talk about pathophysiology of acne, and we talk about acne, how it gets its name based on this bacteria, it's more than just how this anaerobic or low oxygen, rod-shaped, gram-positive bacteria grows. I mean, it's beyond that. It's something that we have to take in holistically. So once again, just to repeat, what's the pathophysiology? We have hormones, basically testosterone for men, estrogen for women, which triggers sebum production. And then this acne, this bacteria proliferates, and we're seeing more evidence to resistance as time goes on.
Are there specific types of acne?
Yes, there are, and they are based on severity. You can have, as the majority of our teenagers do, and again, I say teenagers because that is the primary population because of androgen activity that will develop this. Though I might add, by the way, that if a man or a woman comes in and all of a sudden says to me, listen, you got to help me, I'm breaking out like I was a teenager. If it's a man, they could be 45, 50 years old. One of the first questions I'll ask is, are you taking testosterone injections? And they'll say, why, yes, I am. How did you know? Well, first of all, it would be on the medical history report, or sometimes they forget. And I say, well, if you're taking testosterone injections, which is another discussion for other reasons, you're also going to be developing acne as well. All of a sudden, we got that sebum production. For women, of course, who are premenopausal, that is another time when all of a sudden hormonal activity takes off. I might add that women who say, wow, I only break out with my acne around my period, exactly exemplifies what I was saying earlier, that androgens or the estrogen hormone is active around the period, is that's why it's pushing that excess oil, and that results in proliferation of acne. But going back to your question, are there specific types of acne? It ranges from what's called mild to moderate to severe nodular cystic. So when we look at mild acne, what we're looking at is some inflammation, some redness. You can see some glistening sheen of oil on the forehead, nose, cheeks, and chin. So with that redness and that oily sheen, we might see a few scattered what we call open comedones or closed comedones. Well, what is that? Well, an open comedone would be a blackhead. And what happens is there's some slow oil production, and it'll be kind of gray to black. But if you were to squeeze that out and you looked at it from the side, kind of a core sample, you would notice it's really kind of gray at the top, and then it goes down to white. So what happens is microscopical particles of dirt will get trapped against that sticky, waxy sebum and give that impression of a blackhead. So that's an open comedone. Well, what's a closed comedone? Well, that's a whitehead. And the whitehead is that oil that's trapped under the skin and it hasn't broken open. So if you have a few scattered ones there plus some redness and oil, I would consider that to be mild. Well, all of a sudden we'll go to moderate. Moderate now, we see a few cysts, and they're open, and they're oozing and crusting, and there's some pain involved. The other kind would be the nodular cystic. Now, that's very severe, and this is where it looks like, for really, don't know a better illustration, than it looks like a pizza fell on you, and it's severe. It's very red. It looks painful. The individual has nodules that sometimes are bursting open. It's got almost pus that's coming from it, and huge scars, and it's very, very difficult to look at and imagine how a person is going through that. A lot of inflammation, pigmentation, and we're really able to see this progression of uncontrolled acne vulgaris. I might add that the more severe, the more likely you have stronger hormonal activity, which results in that oil production and a wonderful breeding ground for the bacteria.
Do you have specific goals in mind for treatment?
Yes, these specific goals take place in a really robust, healthy conversation with the patient. I will ask oftentimes, particularly if they're a teenager, because they've been brought in with a parent, mostly because they're a minor, but I will ask and say, let me ask a question. Did your parents bring you here, or did you want to come here? Well, if they say my parents brought me here, I kind of pivot to the parent. I go, so this is more important to you than it is to them. And the parent will admit, usually, yeah, I had to drag them in here. And I will admit, it's the young men oftentimes that they have to drag in. And I don't know what it is about the genders, but if it's a guy that's brought in, usually he could have even severe acne in my book, and they think they're pretty handsome. There's that teenage cockiness. They're God's gift to the world when it comes to how they think they look. Girls, meanwhile, the mother will be crying and there's some tears and I have to pass out some tissues and I'll say, what are you here for? And they're like, acne. And I'll say, where? And they go, well, if you look really close here on my nose, there's a small pimple. And I'm like, oh yeah, there it is. And the girls are usually much more motivated, and the parents combined with them when it comes to the specific goals in mind for treatment. They're going to be very receptive, very open. What I try to tell the guys is, look, I know it's important to your parents, not so much to you. And again, it's not true every encounter, but overall, a lot of guys are like, it doesn't really bother me. And I say, look, let me tell you straight. This is going to get worse, and I think when you get older, you'll probably regret it because you'll have some scars that are permanent. Right now, your skin is more flexible when you're younger, and we can get this under control. So we're going to do this as easy as possible so you're more likely to be compliant, and compliant means that you will be using this on a regular basis, and you won't get discouraged using it. So I think as far as a goal in mind, first of all, have a conversation and then talk about expectations. I let them know that Rome wasn't built in a day and neither will your acne be gone tomorrow. But just while it took a while to get to where they are, they'll take a little bit of time to improve. The FDA says that whatever we set out as a plan, give it about 90 days or 3 months or 12 weeks, whatever way you want to say it to the patient, to see the most improvement. I want to improve and control the condition. I cannot cure acne. I'd love to talk to the person that has a cure, but at this time it's controlling the condition, improving it, and preventing the developing of new lesions and scars. That is paramount to me, and I explain that to the patient as well. I want to get rid of that inflammatory pigmentation, that redness. If they're Caucasian, if they are of a darker race, we have to think about ethnic skin. For example, in the Asian, the Black, Hispanic population, it's going to be kind of a duskier look, kind of a shade sometime or a scale of off-white, and we want to help them there. In fact, I would say for people color or ethnic skin, as we say it, sometimes this is the most profound aspect of their visit, is just improve the pigmentation so I have an even tone. And then we also want to talk about adverse effects and how we can avoid that from the medication regimen. And I let them know that some of the products can be very drying. Remember, I said reverse engineer. If my problem with acne is oil production, I want to go ahead and have a dry environment so the bacteria has nowhere to proliferate. So go backwards, so we dry things so that the bacteria gasps and dies, so to speak. Well, that could also include some drying. So remind them to moisturize as well. So my goals are explaining to them what the condition is, what is their ultimate goal, understand that parents may have a different idea, and then try to be, within a time frame of 2 to 3 months, reasonable about treating this, and they should get better.
Can you list the basics for treatment?
So when we look at treating acne, I had said already a couple times the phrase reverse engineer. We know it's a bacterial infection that, thanks to hormonal activity, produces oil. So let's break that down. Let's go backwards. So I want to decrease the oil, and if it's a bacterial infection, or folliculitis is another term for acne, acne is just a more direct way of describing the folliculitis, then we would use antibiotic. An antibiotic can be of an oral nature, or it could be, of course, topical. We have clindamycin is a popular antibiotic that we find combined with many other drying agents in topical lotions, foams, gels, creams. And we have right now 7 major treatment approaches for acne that I could list for you. So let's go through that briefly. Number 1 is the topical. So the topical therapies are very common. We have over-the-counter benzoyl peroxide, which was about 6-7 years ago, only by prescription. But the FDA saw that it was GRACE, G-R-A-S-E, which is generally recognized as safe and effective. That's an FDA term, so they put it out there to be over-the-counter. And by the way, benzoyl peroxide, here's a real good pro tip. You might see over-the-counter 2.5%, 5%, or 10%. Well, if you're a consumer and you want to purchase a product and you want to get a bang for your buck, wouldn't you want the 10% instead of the 2.5%, right? You may be thinking about gasoline. Well, I want to have a higher, octane instead of a lower octane. Wouldn't it be great to get it for the same price? Please listen carefully, dear listeners. Do not get benzoyl peroxide in higher concentrations for your patients or telling the parents. The reason is 10% kills the bacteria as easily as 2.5%. But with 10%, we have much higher side effect profile of drying. So while benzoyl peroxide is over the counter, and along with salicylic acid, and comes in foams and gels and lotions, remember, the lower the percentages, the better. It's never been shown to induce bacterial resistance, comes in a lot of concentrations in vehicles, and it is found in prescription products as well, combined with clindamycin and erythromycin most popularly. But get the lowest amount, and that may be all that you need. And if you use it on a white washcloth in the shower, maybe 3 times a week to get started, have your patient build up from there. Why did I say white washcloth? Because benzoyl peroxide bleaches. And you never want to give your patient advice to use it in the evening. If you put benzoyl peroxide on and go to bed, if your pillowcase is not white, it's going to be white eventually, or at least splotch that way. So topicals come, like I said, in multiple. And I can't begin to tell you how many there are in just this short podcast. But another popular besides benzoyl peroxide and salicylic acid is azelaic acid. Azelaic acid is prescription. It comes in different percentages, and it's bacteriostatic and bactericidal, depending on percentage. Bacteriostatic means it decreases the load. Bactericidal is it completely destroys the bacteria. There is no inducement of antibiotic resistance with azelaic acid as well. It has superior anti-inflammatory properties, makes things less red. Has not been studied in pregnancy, though we would hope that's not a problem with most teenagers, but it is something to remind them. It's a natural product for those families that want something more natural because it's an acid that's found in wheat, rye, and barley. When these plants are exposed to inflammation or a virus or a bacteria, they give off this product called dicarboxylic acid, and they've made this into azelaic acid. Tretinoin is a hugely familiar product. Tretinoin cream has been around now for decades. Vitamin A cream, older women use it for wrinkles and also anti-aging properties like hyperpigmentation or melasma. But this vitamin A derivative is not to be used with individuals who have high photosensitivity issues, can't have it with women who are pregnant or breastfeeding. But it's highly effective product when combined with oral antibiotic. And I tell my patients start using it about 3 times a week in the evening. Be careful around the eyes as they can really dry, but just lightly put a pea drop amount on your fingertip use it to your forehead, nose, cheeks, and chin, and just kind of build up. See if you can get to using it maybe 4 nights a week, 5 nights a week after a couple months. See if you can do then, every evening after a while, maybe 2-3 months. You can imagine teenagers, they want, in our instant society today, they want treatment now. I want to get better tomorrow. I have people coming to me saying, I'm getting married next month. Can you fix this acne? I'm like, you've got to be kidding me. That is going to be a trick. Just kind of building up, making it a relationship through the teenage years there with their product. Another product that they can use over the counter is adapalene. Adapalene is a synthetic retinoid based on the tretinoin model, and it limits the photosensitivity adverse effect. And I think it's a very good product, adapalene, when you have that rougher, scalier type of acne with the bumps on the forehead and cheeks and nose. So adapalene is a great one, comes in different percentages. Tazarotene is a 3rd-generation retinoid. So we've got tretinoin, adapalene, and now tazarotene, and it comes in cream, gel, and foam bases. And once again, common side effects are sun sensitivity, dry skin, itching, redness, drying, and that's of the like. And remember, moisturize. I tell my patients, look, if you're drying, what are you going to do? Well, moisturize. A newer product that came out about a dozen years ago is Dapsone. Comes in 5% and 7.5% cream. It's a sulfur compound. I find that it's kind of gentle and could be used twice a day and very effective for inflammatory acne. Earlier in the podcast, I said there's a product that cannot be combined with benzoyl peroxide. It'll turn you orange. That's the one. Dapsone cannot be combined with benzoyl peroxide because you will have an orange tint, particularly if you're Caucasian. So that's just probably not the color you want when you go to school. Who knows? So I know this is kind of a longer answer to your question about basics for treatment. There's hormonal therapy, spironolactone. Spironolactone is generally reserved for those who are 25, 30, and older. And spironolactone is not FDA approved for acne. It is a blood pressure medication, a diuretic, but we use it frequently in dermatology as off-label for acne because we found that it blocks the production of excess androgen. It makes kind of a light treatment of that. But because it is also a blood pressure medication, diuretic, it can cause your blood pressure to drop if you're not careful. You'll urinate more frequently, and some people get headaches if they're not drinking water. But in my older patient population, 25, 30, and older women, this is a tremendous product that we usually give 25 or 50 milligrams, one by mouth twice a day. We watch their blood pressure, and because it's potassium sparing, we remind them of what that means. And we have some really good results. People ask me about oral prednisone, and oral prednisone can be used as a systemic approach to really severe acne where it's inflammatory and it's painful. And I'll generally do 2.5 or 5 milligram by mouth every day for about 2 to 4 weeks just to get that redness and inflammation down. Remember, though, there is a type of acne that is caused by steroid acne. So I've never done that in a patient, and I'm just very careful, but I use it as a reasonable choice for painful acne for just a brief amount of time. And at 2.5 and 5 milligram, you do not have to worry about tapering. I also might mention as a specific basic for treatment in this question, oral antibiotic. And doxycycline and minocycline are the most popular oral antibiotic therapies. The FDA and the American Academy of Dermatology have both requested that providers not give oral antibiotic in mild to moderate forms of acne. Their official statements say, please try to avoid that and conserve oral antibiotics for more serious things rather than cosmetic issues, which is what a lot of insurance companies consider acne to be. Interestingly, acne is implicated in severe depression in those 18 and younger. So there's a lot of depression and anxiety. In fact, in some patients, it's led to suicidal ideation. So I have to kind of be careful to reserve oral antibiotics as a provider so I don't have more common community resistance. I get it. On the other hand, how upsetting is this to a child? So So when I talk to a teen, I will sometimes give it, say, minocycline, 100 milligram, one by mouth every day for a month. Usually the best is the extended release, and try to do 1 mg per kg. Works out to be about 100 milligram for most teens. Has very low side effects. But if it's really bothering them, I'll give it for a month, and I feel ethically that I've done the right thing, especially in the light of real depression, anxiety. And like I said, I've seen suicidal ideation with really severe acne where they just want to kill themselves, they say. Well, is that a teenager being dramatic? I can't take that chance. So we do want to be in a good conversation and treat it seriously. I might make one more quick point, is that acne becomes resistant when you find out if the child is going to be serious with the oral antibiotic or not. We ask them to take it with food if they can, not an empty stomach. And if they're not going to be compliant, it's best that they didn't take the antibiotic. We are seeing high resistance with tetracycline, erythromycin, clindamycin, and amoxicillin. These antibiotics are really not working very well. In fact, there are studies back to 1978 and 1996 that showed resistance at 20% and then 62% as far back as 1996. So we are seeing that treatment is getting to be a little tighter. So I talk about compliance. I try to limit the duration of the oral antibiotic. And I try to use the same antibiotic if retreatment is required, because if they didn't have any side effects, which are usually dizziness, upset stomach, or diarrhea or headache, then I would go to that again.
Is there anything a patient might do that doesn't involve making a visit to their pediatrician, primary care provider, or dermatology provider?
Yes, there are some things that don't involve coming to see us as often, and one of them would be using some over-the-counter cleansers that are non-soap. We know that some patients will, for whatever reason, maybe it was a family member, or they read something on the internet, or maybe they just thought to this themselves, that if I'm oily, I'm going to really dry it more strongly. And so I'll have people come in that used witch hazel, or they used hydrogen peroxide, or they did use benzoyl peroxide over the counter, or salicylic, but they really put it on 2-3 times a day. I've heard things with some really powerful soaps that are over the counter that have also a product that might have a high alcohol content. But here's the perverse thing. If you use super drying products on the skin in order to get rid of that oil and kill that bacteria, as a provider listening to this podcast, whether you're right now in your kitchen preparing supper or driving down the road or however you're listening, maybe mowing the lawn and you've got some headphones on, I want you to think, if you dry the skin to excess, how does the body compensate in those areas for all that excess drying? And the answer is, makes more oil. So if you make more oil because the body says, man, I am really dried out, what's going to happen to the acne? It proliferates even worse. So it's kind of strange, because what I'm really looking for in my treatment goals with patients is for them to find balance. So some will come in and say, I have been, really scrubbing my kid's face with even over-the-counter isopropyl alcohol. I'll go, no. You can't do that, because now their acne is worse than ever, because it's making oil even worse than ever. So I want people to find over-the-counter a balance, and that's why I think that benzoyl peroxide in the lower percentage, or salicylic acid, not necessarily used every night, and a non-soap cleanser, and there's many brands and options that could help in the early stages. The reason you might want to see me, of course, is when things are not working for you over the counter. I might make also a mention about the basics of treatment earlier. I failed to include sulfacetamide wash or solution. Sulfacetamide is an analog of sulfa wash, and or I should say sulfa oral antibiotic. It doesn't necessarily mean that you'll have a reaction if you have adverse reactions to sulfa by mouth. But sulfacetamide, which is prescription, is also another great product. But again, something you can do at home would be cleansers, just taking off that little excess oil. Remember, we need oil on our skin. There's a purpose for oil. It's to keep us hydrated, and it's kind of a natural lotion. It's just that excess part we want to keep down.
Accutane has been a controversial topic for many years, and people can read frightening things on the internet. What are your thoughts about Accutane, and when should it be used?
Wow, I wondered if that question would come up in this podcast, and I'm so glad that you've asked it. Accutane technically doesn't exist any longer because they lost their patent. It was developed in 1982, and that's almost 40 years now, and it is now in multiple names, of course generic, everything's generic, but I think of Sotrate or Clarivis or Roaccutane or just plain isotretinoin. There's also Absorica that's out there, which is a different formulation, but it is essentially the same thing. Accutane is a purified form of vitamin A, and what it's famous for is kind of two-pronged. Number one, it's famous for being the closest thing we have to curing acne. And I know it's a bold statement. I'll say it again. It's the closest thing we have to curing severe nodular cystic acne or resistant acne. And that's great. But it's also very famous because of its side effects. And it's a highly regulated medication, and for good reason, because if you took this medication and you got pregnant, or a male got a female pregnant, the baby will be deformed. I mean, it's just predictable and consistent. The child will have major deformities, and that is of great concern. Second of all, if you take this medication and drink alcohol, you can become violently ill. And blood work is required prior to prescribing it to see if there's any liver or lipid abnormality. Now, that sounds really, really frightening, but I can tell you that this has been one of the medications that creates an emotional response in parents and patients like I've never seen. I mean, tears of joy, thankfulness, appreciation. Because if you follow the basic rules, which are don't get pregnant or don't get someone pregnant, don't drink alcohol, and just watch your liver through the blood labs. And right now the recommendation, it used to be that you had to have blood drawn every month, but all the research has shown if you just take it before getting started and then wait a couple months and take it a second time, and if it really hasn't increased your triglycerides or cholesterol to a point of concern where there's no AST or ALT values that have gone up, you know what? I prescribe this medication, are you ready for this? Probably to 500 people a year. I mean, that's a huge number. Now, think about over the years doing that. I have never sent anyone to the hospital or the emergency room in my career when it comes to this product when you follow the rules. Have I sent people to the emergency room thanks to antibiotics? Yeah, about once a year. Someone will have a bacterial infection. I ask them if they're allergic to this antibiotic. They say they don't know. We give it to them because it's the right drug for the right bug. And we find out later they had a drug reaction, hives or a lot of itching, something like that. And I'll say, I'm so sorry. But I've never sent anyone to the hospital with this medication, and it's one of the greatest things in healthcare today when you follow the rules. Here's why it's so good. Number one, we have some acne that is completely resistant to antibiotic, just hands down. It's not going to work. It's never worked. You've combined it with prednisone. You've used lots of topicals. Nothing's happening. Number two, severe acne increases suicidal ideation. And the largest study of its kind, which was done back in, I guess it's now about 20 years ago, they had 9.6 million patient visits, failed to demonstrate any association between isotretinoin use and increased depression or suicide. There's a big belief that this medication causes depression or suicide. It doesn't. You know what causes depression and suicide? Severe acne, not this medication. Now, I think what happens is in some patients, they've read on the internet or they talked to someone who thought that they had that medication and they felt depressed and it was almost like a self-fulfilling thing. But it's just not been shown to do that. So what happens is a patient comes in, and what we do if it's a male, we ask for the blood work, and we enter them and females into what's called the iPledge system. The iPledge system is a program that protects both the patient and the provider and reminds them when they're under 18 to fill out this form with their parent that they know not to get pregnant, to come in every month. I can only prescribe 30 pills. And if it's a female, they have to have 2 negative pregnancy tests prior to starting. So they come in, they have a pregnancy test, wait 30 days, have a second pregnancy test. By that time, I have the blood work. I can give them the 30 pills. Dosage is generally about 1 milligram per kilogram per day. And what we want to do is treat them for 5 months. At 5 months, we find out, according to research and experience, is kind of the sweet spot. More than that, you're spinning your wheels in side effects territory, which is dry lips, dry eyes, dry nose, and dry skin. That's the side effects. Dry eyes, dry nose, dry lips, dry skin. And if something's dry, we moisturize. And they have to go online, particularly the females, that they answer the questions. They have to promise that they not get pregnant while they're on this product, but if they engage in sexual activity, they have to have 2 forms of birth control. And I'm telling you, it has shown in study after study, no increased suicidal thoughts reported or documented. The female patients were at a higher risk for needing the medication again later in life just because of that hormonal activity, but it's the closest thing to a cure. And we have just had, in our experience, I work with 35 to 40 providers, and it's just been a very, very good product when we follow the rules. The efficacy and safety, the evidence of research has been tremendous. In fact, some mood improvement has often been observed. I might make mention on the depression part why that continues to be in our mythology of healthcare today. People say, I don't want to give it because it could cause depression. I've given it to young people who suffered from depression and were on antidepressants, and I gave them this medication. And after they cleared and looked so good, they weren't even taking their antidepressant medication or anxiety pills as being given by other primary care provider. And they checked with the primary care, and they just said, yeah, they're much better. But let me share with you just quickly to our listeners why depression was and continues to be percolating in the back of people's minds. When the first studies were done, they used what population would you consider that they would use for acne? Teenagers. All right. And who usually had the more severe between the males and females? Well, in those early studies, it was females. So they had 14, 15, 16-year-old teenage girls, and they noticed, as they should as good researchers, that there was a lot of lability, or they were emotionally up and down. They would slam the door at night, tell their mother they hate them, and then in the morning they would tell their mother you're the greatest mother in the world. They would cry very easily. They'd get emotional about certain things, that they don't have the right dress for the prom. And all the researchers had to document that. They were like, wow, this medication is really causing these kids to go up and down. Come to find out, some of the researchers said, we have daughters that are not on this medication. This is exactly the way they are. So when you factor in the average teenager's emotional ability, how they respond to things at this time of life, then you kind of say to yourself, maybe it's not the medication. So once again, I'm not saying that this is candy. You have to be approved by the FDA to be in the iPledge program. I am. I take it very seriously. I talk to every patient directly. When you get the actual medication, there is a picture on every pill of the packs where it's a pregnant belly and there's a slash through it. So they're reminded. So while it's been controversial for years and you can read frightening things, I have had nothing but the best experience along with my colleagues and patients. So I reserve it for very resistant acne and also for severe nodular cystic. And a lot of parents now are bringing in their kids. You know, after almost 40 years of the medication out, we now have people come in and say, I was on it. I want you to put my kids on it. We had a great experience.
Can diet play a role in acne? I've heard all kinds of issues regarding foods ranging from greasy foods to chocolate. What does the research say?
Well, that's something I continue to hear on a regular basis. And the short answer is no and yes. Well, what does that mean? Well, you asked if diet can play a role in acne. I would say yes to that. As to greasy foods and chocolate, probably no. And I'm about to tell you something that could surprise a lot of folks and maybe disappoint. So what is the skinny, so to speak, on acne and diet? Well, we know that foods that increase insulin levels magnify the male hormonal effect, predominantly with testosterone. And the group of foods that is most implicated in boosting insulin and is itself high in hormones is made by pregnant cows that produce milk. So if we can avoid dairy, which is kind of the heart of the American diet, and sugar, and lessen oils, if we can avoid dairy and sugar in particular, which is very inflammatory, and we can lessen oil stimulus production. Let me give it to you in this way. When we know teenagers are developing in their bodies, in men, they're growing hair on their face, their voice is dropping. In females, there's the production of breasts, and the body is now getting ready to make babies with the monthly period. We know all of that, a very natural process and expected, but what is it that can magnify this oil production down the line? Well, interestingly, wherever the Western diet follows, acne appears as well. Acne is not in a lot of tribes, deep in certain forests and around the world, and it's not in certain areas. But if you start eating the Western diet, which is heavy on dairy, we get in trouble. Remember, the human being is the only mammal in the history of the world that has never let go of breast milk. We just go from our own mothers to another mammal, the cow, or to a lesser extent, sheep and goats. When we make cheese. And in some cultures, they continue with that as well. So we go ahead and we take milk from a dairy cow that was meant to grow a 300-pound calf to 1,500 pounds, and we give it to our teenagers. Well, what's that going to do to their hormonal activity? Because it's very close. It's still mammalian. Well, that's where I have a mother come in and say, yeah, my kid drinks a gallon or two of milk a week. It's unbelievable, but I'm glad he's drinking it because he's building strong bones. And, of course, we need milk as part of our diet. And I just shake my head and I go, no, we don't. We like it. We make butter. We add sugar and have ice cream. We make cheese, and it coats the inside of our mouth, and it's that fattiness. And it's really hard to have a day in the American diet without cheese. But we were never meant to have milk throughout our entire lives. We fooled ourselves into believing that. And what happens is, we now add this to the teenage diet, and the explosion of additional androgens in the body, this hormonal effect, really creates severe acne. So that's why anybody that is researching acne asks you to limit dairy. I mean, that's the reason right there. It's no question that diet plays a role in conditions like rosacea, for example, and we know that acne looks like it. Of course, it's a different process. Rosacea is an inflammatory disease where acne is essentially a bacterial proliferation with oil. But I ask my patients to avoid dairy and sugar to lessen that oil stimulus proliferation and production. And I know this is highly controversial to some to adjust to that extent. But it is supported by the research and the data, and it's pointing very close to that. I can imagine, though, somebody right now listening saying, well, what do I tell my patients when it comes to vitamin D production? Well, first of all, I'm not against the sun. I think we need 20 minutes of unfiltered sun every day. That assists in vitamin D production. Even in dermatology, we need sunshine. I'm not a person that believes in covering up completely and never getting any sun. Number two, we can get a lot of vitamin D from diet. It's amazing how many leafy green vegetables, like even kale, can give you all the vitamin D that you need for the day. Yeah, well, I don't like kale, someone will say. Well, then that's a matter of adjusting and a matter of taste. But don't tell me that you need milk production all your life and then wonder why you get such bad acne. So if you're serious about foods playing a role in telling your patient to do something more natural, I would point to dairy.
Do you have any final thoughts on acne, future treatments, or discoveries?
There's some disappointment in your question because I don't have a great answer to tell you about future treatments or discoveries. Right now, what's happening is that manufacturers looking for the next great thing are looking at combinations of antibiotics with classic benzoyl peroxide or salicylic acid. Without revealing the company, because it's proprietary, I was asked recently to spend an hour or two online going over a product that they have in development, and I was probably disappointing all the researchers at this pharmaceutical company, and I said, you have nothing new. I said, it's what I guessed that you would have, which is benzoyl peroxide, and you're mixing it with a common antibiotic, and it's nothing that we don't already have out there. So they were kind of like shrugging their shoulders saying, yeah, you're right. So we know what the topicals are that are out there, and, adapalene, tazarotene, dapsone, tretinoin, azelaic acid. So all these products that are out there, they're just combining with over-the-counter benzoyl and salicylic. So really, we don't have much more new. And we don't have a lot of new antibiotic that's indicated for that as well. We just have the old standbys of minocycline, doxycycline. I do not recommend tetracycline because of the resistance and the chance of staining the teeth permanently, particularly if they're younger. I can only say that keeping in touch with different pharmaceutical companies and the research trials and things that are in phase 2 and phase 3 trials, we don't really have much more new. On the other hand, we do still have a wonderful stable of products that if we can combine them in the correct combination for our patients, we have generally a very good, predictable outcome. And that's where we are right now. So finding the right combination with what's available, both over the counter and what's prescription, and reminding young people and the families that, like many things in the world, this too shall pass. Fortunately for most, this is a phase, and we'll get through it together.
This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer.